you tell me your Once again, congratulations.
Thank you. हमको कुछ बोलना नहीं है. हमको बोलेंगे बोलेंगे नहीं.
Actually, CM this was it
नहीं मैं कुछ नहीं बोलूँ. मैं अभी सबका अच्छा नहीं लगा. आपने फोन किया इसलिए सेट किया. तो मुझे बोलने के लिए मत फोन करना.
ठीक है.
क्योंकि मैं मेंटली प्रिपेयर नहीं.
Right.
Thank you. Thank you. ഈ മേലാന്ന് ഞാൻ വീട്ടിലേക്ക് വിളിച്ചായിരുന്നു. ആദ്യത്തെ ഞാൻ കണ്ടാൽ വാക്സിൻ സ്ലിപ്പായി പോവുകയാണ്. വണ്ടി ഇല്ലാതെ അവിടെ നടക്കാൻ എനിക്ക് പറ്റത്തില്ല. അപ്പൊ ഒന്ന് രണ്ട് പേരോട് ചോദിച്ചപ്പോൾ അവർക്ക് സ്കൂട്ടറേ ഉള്ളൂ. അതായത് വണ്ടി എടുക്കാൻ പോയത് ഞാനിത് കണ്ടായിരുന്നു. ഒത്തിരി മെസ്സേജ് കണ്ടത് എന്റെ മനസ്സിന് സ്ലിപ്പായി പോയി. ആക്ച്വലി നിങ്ങൾ വിട്ട ലെറ്റർ ഉണ്ട് ഇന്നാണ് കിട്ടിയത്. അപ്പൊ അതാണ് എത്തിയത്. അപ്പൊ ഞാൻ വെനു മാറി നമ്മൾ ഇവിടെ എഴുതിയായിരുന്നു. ഞാനത് വായിക്കുകയും ചെയ്തു. അപ്പൊ ഞാൻ ഓർത്ത് വെനു മാറിയത് കഴിഞ്ഞിട്ട് ഈ ലെറ്റർ എന്താ ഇങ്ങനെ വന്നത്. എന്നോടൊന്നും പറയാനൊന്നും പറഞ്ഞില്ല. കാരണം എനിക്ക് മേല അല്ലെങ്കിൽ ഞാൻ മെന്റലി പ്രിപ്പയർ ആയിട്ട് വന്നാണ്.
Good afternoon all. I welcome you all who have joined online and offline. Our dignitaries are supposed to arrive shortly at 2 o'clock, but due to some other programs, we are little delaying our program. So we'll be starting our program soon. Please be patient and stay connected. Thank you.
Madam, here.
यहाँ पे
We'll shift it.
हम इसको शिफ्ट कर लेते हैं.
Thank you. Thank you.
Sorry, did I keep it?
नहीं मैं खुद सॉरी है. मैं खुद ही लेता है.
Lecture Yeah, in charge principal.
You Yadia.
Yes.
Oh, we talk on the phone.
Yes. The thing is, CMS sir and CMS sir are very busy. it seems.
That's fine. We can
Yes,
start
sir.
now. We can
Yes, sir.
make them join when they come.
Yeah.
What do you
we can
say?
go ahead.
I
Yes, sir,
think
that we
why
can-
keep the kids waiting?
That's fine. Very soon.
Yadia चला गया कि production. इसको क्या है? Thank you. डॉक्टर ओपी संजीव को यहाँ बुला लें. डॉक्टर ओपी संजीव. डॉक्टर संजीव को इधर बुला लें. कर दो. But it will be 5 seconds. बच्चे बेचारे सो जाएं इससे अच्छा है कि हम कर लें. ठीक है. ये कौन? पियानिस्ट तो नहीं है. मतलब
Artist picture.
एक बात सुनो.
Yes.
शॉर्ट कर दो ना प्रोग्राम.
हाँ.
बच्चे भी फिर सोएंगे नहीं.
सही.
जगे रहेंगे. आपका प्रोग्राम ये था. इसमें आपको डॉक्टर गौरव और डॉक्टर पालीवाल नहीं है और हर्षवर्धन भी नहीं है. ठीक है. और वी शुड जस्ट स्किप दिस एंड गेट टू द मेन प्रोग्राम. आप 2 मिनट का ओपनिंग रिमार्क्स बोलो, वेलकम करो और स्टार्ट करो. I feel that we can skip all these 3.
Yes.
Come to the main point. Mr. Yadia can do the inaugural and the inaugural remarks, and then come to the point. If CMS, MS or Dr. Harshvardhan कोई आ जाते हैं तो उनको ज्वाइन बीच में वेलकम कर देना और उनसे कुछ बुलवा देना. ठीक है. After the end of that talk, बस इतना काफी है. But CMS has said now that we can go ahead. CMS ने बोला ना.
Yes.
बात हो गया ना. ठीक.
Actually, Pandya sir और गौरव सर दोनों साथ में. So CMS sir फोन नहीं उठाया. दोनों साथ में हो गया.
A very good afternoon to one and all. The world is full of diamonds and gems, and we are having some of them here today to build this event. With this note, I am Merlin Chima. On behalf of College of Nursing, I feel privileged to extend a very warm welcome to all the dignitaries on the dais and off the dais, and all who have joined through online to the seminar on World Zoonoses Day. It is an occasion like this, we get opportunities to test and enhance our knowledge. I look forward to get an exposure about what the best of the brains think about various new zoonotic diseases in current scenario. Let us invoke God for his blessings before we start the blessings. I request Roli Shukla and her companion to lead us in prayer.
इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना. इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना. हम चले नेक रास्ते पे हमसे भूल कर भी कोई भूल होना. इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना. दूर अज्ञान के हो अंधेरे, तू हमें ज्ञान की रोशनी दे. हर बुराई से बच के रहे हम, जितनी भी दे भली जिंदगी दे. बैर होना किसी का किसी से, भावना मन में बदले की होना. हम चले नेक रास्ते पे हमसे भूल कर भी कोई भूल होना. इतनी शक्ति हमें दे न दाता, मन का विश्वास कमजोर होना। हम न सोचे हमें क्या मिला है, हम ये सोचे किया क्या है अर्पण। फूल खुशियों के बाटे सभी को, सबका जीवन भी बन जाए मधुबन। अपनी करुणा का जल तू बहा के, कर दे पावन हर एक मन का कोना। हम चले नेक रास्ते पे, हमसे भूल कर भी कोई भूल होना। इतनी शक्ति हमें दे न दाता, मन का विश्वास कमजोर होना। मन का विश्वास कमजोर होना, मन का विश्वास कमजोर होना।
Very nice.
Thank you, students. In the beginning, I would like to request Mr. Yaditya, lecturer, College of Nursing, for opening remark and welcome note.
So he's not principal.
Good afternoon, everybody. So happy that the College of Nursing is organized the Zoonoses Day celebration on 6th July, and I'm here to welcome all of you. First of all, I welcome Dr. Gaurav Agarwal, CMS, and Dr. VK Paliwal in their options here. Hope they will join shortly because of other program. Their timing is delaying. And also, I welcome Dr. Harshvardhan because of her mother's ill health. He is also not able to join us today. And next, I welcome Dr. Prerna Kapoor, Nodal Officer for RNTCP and also Senior Physician, SGP PGIMS Lucknow. Welcome you, ma'am, being with us and going to share her knowledge with us today. And also, I welcome our CNO, madam, and congratulating her for being a first CNO officially designated. And we are so happy, madam, to have you with us in this program. And also, I welcome Dr. A.K. Barnwal, veterinary scientist, Animal House, SGPG Lucknow, is going to deliver a lecture today. Also, Dr. Vishal Gupta, Department of Microbiology. I welcome Dr. O.P. Sanjeev, Associate Professor, Department of Emergency Medicine, SGPGMS Lucknow. Also welcome Mr. Dikhil CD, Quality Nurse Coordinator, Hospital Administration. And I also welcome all my colleagues and the other nurses and in-charge nurses and staff nurses and my dear students and my friends for this occasion of celebrating Zoonoses Day. And really it is very important to make a note of it because these are the diseases which are very much neglected in our society. But when we celebrate those such events, then definitely at least few attentions we can seek to that burning issues also. Okay, and I myself is a victim of zoonotic disease, and I suffered pediatric cyst. Okay, I undergone a surgery for that, and because I'm a pet lover, I love dogs so much, and from childhood I had a dog with me, and now also I have a dog, and I've been diagnosed as a pediatric cyst in my spleen and also in my liver. So I think in December 2021 I have been diagnosed, but that I was affected in my childhood itself, as per a doctor's assessment. So that means there are risks of having pets with us and having cattle with us and working with them, playing with them, and using them for our daily usage. And really, I hope that today's lectures will be very useful for the students and also the participants from offline and also online. I welcome you all for this session. With this small introduction and keynote address and welcome, I thank you all for this wonderful time which is given to me. Thank you, Ananda.
Of delay in arriving our dignitaries for inaugural session, we are directly entering into the most important events of the seminar, that is scientific session. Knowledge is like a garden. If it is not cultivated, it cannot be harvested. Human being biggest wealth is knowledge. It cannot be robbed and always increases by sharing. Teach what you know. Sharing knowledge is a charity of knowledge that constitutes the ways of a beautiful life. So here we have 6 speakers to share their knowledge on different aspects of zoonotic diseases. To begin, I would like to call Dr. A.K. Baranwal, veterinary scientist, Animal House, SGPGMS, Lucknow, to talk on zoonosis and lab animals, challenge and way forward. When I say his contribution is lot, but I am mentioning a few of them. He had worked as both research biologist and research scientist in Calcutta and has professional work experiences in different fields like animal models, animal kinetic studies, and animal efficacy studies, etc. And also, I would like to call Dr. Prerna Kapoor, Nodal Officer for TB Control Program, GH, to moderate this session.
I'll sit here and moderate. Is that okay? Okay?
I think, yeah, mic is there.
We have to adjust mic.
So we have to?
Mic
Okay.
is
We have to
there.
adjust.
मैं तो हर जगह से सुनाई दे जाती हूँ.
Yes, yes, I think.
मेरी आवाज तो बुलंद है सारी.
Namaskar, Dr.
I can start. Okay. Okay. So just a very brief introduction to the first talk for today. वर्ल्ड ज़ूनोसिस डे हर साल 6 जुलाई को ऑब्जर्व किया जाता है. ये इसीलिए है, जैसा कि उन्होंने अपने भजन में बताया, कि अज्ञानता से हमें ज्ञान की तरफ जाना है हमेशा. तो वेरी फ्यू ऑफ अस आर अवेयर कि ज़ूनोसिस कितनी इम्पोर्टेंट एक एंटिटी है, जो बीमारियां हैं जो जानवरों से हम में और हमसे जानवरों में भी जाती हैं. ऐसा नहीं है कि हम बहुत शरीफ हैं और जानवर ही सिर्फ खतरनाक है, इंसान भी काफी खतरनाक है. तो जो है ये बीमारियां बोथ फेज जाती हैं. दे कम फ्रॉम एनिमल्स टू ह्यूमंस, दे गो फ्रॉम ह्यूमंस टू एनिमल्स. सो we must know about them so that we can tackle them, more importantly so that we can prevent them. COVID was a zoonosis. Dr. Vishal, who's a microbiologist, does not always agree with me on this. Jury is still out on this, but COVID was a zoonosis is what we think. Rabies is a zoonosis. Monkeypox is a zoonosis. There are a lot more. Hydrated cyst, यादिया जी ने बताया कि इनको हुआ था. तो ऐसे बहुत सी ऐसी बीमारियां हैं जो प्रिवेंटेबल हैं. और फॉर्चुनेटली नंबर ऑफ डॉग लवर्स, नंबर ऑफ पेट लवर्स हमारे देश में और विश्व भर में बढ़ता जा रहा है. लेकिन उससे फिर ये थोड़ा सा रिस्क है ऑफ कॉन्ट्रैक्टिंग zoonosis. एंड डॉक्टर A.K. Baranwal is actually a scientist who is associated with our animal house. He looks after that and experimental animals. He has very vast knowledge about this topic, and so he is going to tell you all ke what does zoonosis mean, and lab animals को जब हमें टैकल करना है तो क्या हमें कोई खतरा है या नहीं है. आगे चल के आप लोगों की किसी की भी ऐसी पोस्टिंग्स हो सकती हैं या आपको एक्सपोजर हो सकता है. So you should know about this. Thank you. Over to Dr. A.K. Baranwal.
Respected moderate, thanks for your kind words. Respected faculties, research employees and participants, who have joined offline and online. Today we will discuss zoonosis and lab animals, challenges and way forward. So every year on 6th of July, we celebrate this day in honor of French biologist Louis Pasteur, who was really a great scientist, and he has introduced anti-rabies vaccine on the day 6th July 1885. Zoonosis is a Greek word made up of two components, zoon and nozoon, which means animal and disease. And this term was introduced by Rudolf Virchow. As per WHO, zoonosis are those diseases and infections which are naturally transmitted between vertebrate animals and man. So initially it was thought that zoonotic diseases has jumped from animal to human. CDC further elaborated its etiology and other aspects, and it could be viral, bacterial, parasitic, fungal, etc., etc. Now let me understand the mode of transmission, which is really very important. It could be direct contact with saliva, blood, urine, mucus, feces of infected animal, as well as petting and touching, and bite and scratches. So if we are dealing with animals, we should be aware of these different mode of transmissions. Another mode could be indirect, where we get infected while roaming in areas where animals live and roam, and also get infected by coming in contact with ancillary objects like aquarium, pet habitats, barns, pet food, water dishes, etc. Another mode could be vector-borne, and here we are being bitten by the ticks, insects, mosquitoes, etc. So they serve as the vector, means like postman. Another mode could be the food-borne, where either we are eating or coming in contact with contaminated food, and kindly note unpasteurized milk, undercooked meat, egg, raw fruits and vegetables. Raw food was very highlighted during spreading of Nipah virus. And the last one is waterborne. Here either we drink or come in contact with the contaminated water. Regarding epidemiology, CDC has highlighted that about 60% of infectious disease have spread through animal, means zoonotic in nature. And more dangerous scenario is about 75% of emerging infectious diseases are somewhere of animal origin. So based on transmission, we can divide zoonosis in different subsegments. Anthropogenosis, where disease comes from animal to human, brucella, rabies. This list is endless. Another mode could be zooanthroponosis, where disease is being transmitted from human to animal. And tuberculosis is very alarming disease here. Then amphigenosis, where disease may travel in either direction. And very important, eugenosis, where human is obligatory host, about which we learned in our introductory lecture by Aditya sir. This list is very endless, so let me get in very brief. Zoonotic disease could be bacterial, viral, parasitic, fungal, rickettsial, chlamydial, protozoal, and very importantly, acellular non-viral pathogenic agents, which is called prion. It causes mad cow disease in animal and CJ disease in human. Now coming to the next portion, the prevention and control of zoonotic diseases. In very short, there are 4 types of surveillance which is practiced: pathogen surveillance, then sero surveillance, it is community surveillance. Third is very important, syndrome surveillance. We got some set of symptoms through huge data analysis which help us to detect early symptoms based on which we can diagnose any zoonotic disease, and the risk surveillance that you know very well. At personal level, personal hygiene management and personal protective equipments help us a lot to fight against zoonotic diseases. Proper disinfection and sanitation, and kindly remember proper disposal of general and bio waste. This waste is very potential source of zoonotic diseases. And last but not the least, continuous education and training. And for control, we have to treat the individual as well as mass vaccination drive helps us a lot. And kindly remember, vaccination is always an economic option in comparison to individual treatment. Now coming to the laboratory animals. Laboratory animals are exclusively bred and allotted or traded for experimentation purpose only. And the biggest challenge and the key success of laboratory animal house management is to maintain entire animal colony without any treatment. And how we achieve this? We maintain control environment where light, air, sound, everything, room temperature, humidity, everything is well managed, and strict sanitation protocols. And these all measures make your laboratory animal safe of any zoonotic diseases itself and their transmission. In spite this, there could be 2 breaches. One is zooanthroponosis, where either animal handler or experimenter may transmit disease from human to those animals. And the second is exposure of wild counterpart of that particular animal species. So in the last, let me understand how we can control and prevent spread of zoonotic diseases in laboratory animal facilities. And it is very important because we are almost 100% sure that there is no disease occurrence, no disease transmission through the laboratory animal. So we have to maintain very high standard for maintaining that facility and not getting infected from animal or not giving any infection to the animal. So first and foremost is, which is very important, hand wash at start and end. Many times, mostly we wash our hand at the end, but we forget to wash at start. Then donning and doffing, and kindly remember, it must be in correct order. हम randomly ऐसा नहीं कि कभी gloves पहन लिया, कभी mask पहन लिया, कभी gown पहन लिया, कभी कुछ भी उतार दिया, नहीं. There must be a proper order, because our PPE itself could be potential source of infection to us, to our lab, to our community. शू कवर पहन के लैब से बाहर निकल के रोड पे भी रोम करते हुए लोग दिखते हैं. We need to prevent it. So here is the correct order: donning and doffing. And please do not eat and drink inside the animal room and inside the animal lab. Don't sit on the platforms where animal experimentations are going on, or any animal instruments, or any animal belongings, racks, cages, etc. And please, don't offer any gathering of family and friends, relatives to the animal facility, and it's not the zoo. So please don't bring or don't call children to the animal facility. Get vaccinated before start of work. Please remember, get vaccinated before start of work. So if we are going to deal with the Macau facility, we need to have the rabies and hepatitis B vaccination. So it depends on of what type of work you are going to be involved with, and get trained. It's really very important. We are regularly running the training courses under 0102 programs. So whoever is willing and wishing to be part of animal experimentation, it's open for all. You can join there. And even after that, you got the bite and scratches. And actually it happens due to poor handling. It happens due to poor handling. Rat कभी भी अपना hand आपके सामने नहीं करेगा कि आप blood निकाल लो. आपको इवन अगर केज भी चेंज करना है, यू हैव टू पिक द एनिमल. वो खुद से नहीं जाएगा कि बेटे उस वाले केज में चले जाओ, हम तुम्हारा खाना पानी पहुंचा रहे हैं. यू हैव टू पिक, होल्ड एंड ट्रांसफर द एनिमल. सो ऑलवेज there is only chance of bite and scratches if we had developed the poor handling methods. But if unfortunately it happens, it may develop secondary infections, which are not basically zoonotic, but you may develop secondary infections. And secondary infections is of really very great concern. So we should be aware of it. Immediately report it to your mentor, to your animal house in charge, to your animal house veterinarian, and wash very properly with water, soap, and antiseptics, and seek the medical consultation. And at the last, it is suggested and requested, kindly go through the One Health program, which is the need of time across world. It's a global requirement, and it is specifically required for food safety, zoonosis, and antibiotic resistance. Thank you so much.
Thank you, Dr. Baranwal. That was actually very educational, not just for the students here, but for all of us. बहुत सारे ऐसे aspects आपने बताए about animal handling, जो सभी के लिए बहुत ज़्यादा enlightening थे. Thank you. यहीं से बैठे बैठे बोलूँगी. अरे कितनी बार हिला तो यार. यहीं से बोलूँगी.
मैं वहां से
अच्छा तुम्हें वहां हो. ओके फिर आ जाते.
मैडम
अभी मेरा नहीं.
Thank you, sir, for illustrating us with your vast knowledge, especially how to prevent and control zoonotic diseases. Thank you, madam, for moderating this session. Now, I would like to invite Dr. Prerna Kapoor, Nodal Officer for TB Control Program and Senior Physician, STPGMS, to speak on the topic rabies. Prevention is better than cure. This would be moderated by Dr. O.P. Sanjeev, Associate Professor, Department of Emergency Medicine, SGPGMS.
Now I request Dr. Prerna Kapoor to please begin with the talk.
Thank you, Dr. O.P. Sanjeev. Am I audible to everyone? And my slides are visible. First of all, thank you to College of Nursing for organizing this session today. I hope कि किसी भी बच्चों को हम सुलाएंगे नहीं आज, के और सुन सकेंगे ये सारे टॉपिक्स। बहुत छोटे छोटे टॉक्स हमने ऑर्गेनाइज करे हैं और वी होप कि आपका अटेंशन हमें बरकरार मिले। So coming to my topic, which is on World Zoonosis Day today, we are talking about rabies. इसका तो सिर्फ क्योर ही प्रिवेंशन है, इतना तो सभी लोग जानते हैं। तो क्या है रेबीज? जो कि जो है किसी भी जानवर के काटने द्वारा होता है इंसानों में, उसको हम रेबीज कहते हैं। ज्यादातर डॉग के काटने से होता है, थोड़ा बहुत, मैं हिंदुस्तान की बात कर रही हूँ, थोड़ा बहुत कैट और मंकी के काटने से भी होता है। काटने से भी हो सकता है, स्क्रैचेस से, या यदि कहीं पर आपको चमड़ी में घाव है तो उसके ऊपर यदि उस जानवर ने लिक किया तो उससे भी हो सकता है। जो जानवर खुद रेबीज वायरस से ग्रसित है, जब एक रेबिड एनिमल जो है वो आप किसी मनुष्य को काटे या लिक करे या स्क्रैच करे तो इसके ट्रांसमिशन की संभावना। सो इसको मैड डॉग डिजीज भी कहते हैं, बट एक्चुअली ये वायरस द्वारा होता है। और इसके बारे में जानना क्यों जरूरी है? क्योंकि ऑलमोस्ट ऑलवेज it leads to death. There are a few case reports in the world of people who got clinical rabies and survived, but most often it will lead to a very horrible and painful death. So prevention, again I will reiterate, is probably the only cure. So it's a viral disease. It is transmitted by animals. There is no cure. जिस जानवर को रेबीज होता है उसके सलाइवा में वायरस होती है और इसलिए जब वो काटता है तो वो ट्रांसमिट होती है। ये जो बार बार हम कह रहे हैं once a patient has rabies death is 100%, ये आप सोचेंगे कि कितना डरा रही हैं डॉक्टर प्रेरणा। सच बात है, डराना हम चाहते हैं, डरना चाहिए। डरेंगे हम तभी इसकी प्रिवेंशन के बारे में सोचेंगे। तो रेबीज जब भी कोई जानवर इस तरह से काटता है तो द वायरस gets into our body, attaches to nerves near the bite site, then it starts moving towards the brain और स्पाइनल कॉर्ड से होकर ये ब्रेन तक पहुंचती है और पैरालिसिस और बहुत से और कॉम्प्लिकेशंस कॉज करती है। पहले बाइट होता है, उसके बाद वायरस मल्टीप्लाई करने लगती है। इसमें 20 से 90 दिन, अंदाजन करीब 3 महीने भी लग सकते हैं। शुरू में बाइट के टाइम पर हो सकता है फ्लू लाइक इलनेस हो, विच ऑल वायरसेस कॉज, फिर उसके बाद और स्प्रेड करती है, अल्टीमेटली कोमा और डेथ हो सकता है। ये इसके जो सिम्टम्स होते हैं, मरीज को 3 तरह के सिम्टम्स होते हैं, फोटोफोबिया, एरोफोबिया एंड हाइड्रोफोबिया। हाइड्रोफोबिया के बारे में सबको पता है, दैट इज द क्लासिकल सिम्टम ऑफ रेबीज के मरीज को यदि पानी देखे तो लैरेंजियल स्पैज्म होने लग जाता है और डरने लगता है बहुत ज्यादा। लाइकवाइज लाइट के प्रेजेंस में भी उसको बहुत डर होता है। और एक बार, कई बार जो इफ समबडी इज अ वेरी कीन क्लिनिशियन, तो जो वो ऑब्जर्व करते हैं इवन बिफोर हाइड्रोफोबिया द पेशेंट में गेट एरोफोबिया। मतलब कोई कोई मरीज जो हमने देखे, पंखे की हवा से उन्होंने बोला कि मुझे डर लग रहा है, या वो लैरिंगोस्पैज्म में चले गए। सो वी रियलाइज दैट दिस पर्सन इज गोइंग ऑन टू हैव clinical rabies. So there is photophobia, hydrophobia and aerophobia. These are the cardinal signs and symptoms. There can be dumb rabies, there can be paralytic rabies, there can be many types of rabies. All are painful even to watch. These pictures are just meant to scare everyone, so that everyone is aware anytime anybody is bitten, या हम में से कोई या हमारा कोई फैमिली मेंबर या पेशेंट या फ्रेंड्स या चिल्ड्रन, वी शुड नो व्हाट टू डू। सो हिंदुस्तान के आंकड़े काफी भयानक हैं। Every 2 seconds one person gets bitten by a dog. It is equivalent to over 2 deaths per hour. It's highest in the world. And unfortunate thing is 40% of the victims are children. बच्चे क्योंकि छोटे होते हैं और जानवरों के बराबर आते हैं, तो इसलिए उनको फेस और नेक रीजन में बाइट्स ज्यादा ऑफन होती हैं। नाउ दोज बाइट्स आर मोर स्केरी, क्योंकि वायरस को बहुत कम टाइम लगता है ब्रेन तक ट्रैवल करने में। सो जस्ट टू रिकैपिचुलेट, दीज आर ऑल द एनिमल्स जिनके बाइट से रेबीज हो सकता है, लेकिन इनमें से सबसे कॉमन डॉग्स, कैट्स एंड टू अ ह्यूज एक्सटेंट मंकीज हैं। सो अगेन, dog, cat, monkey, sheep, goat, cow, buffalo, all warm-blooded animals can actually transmit rabies. Wild animals में जिससे होता है नेवला, लोमड़ी, फॉक्स, जेकॉल, कैमल्स और एलिफेंट से भी कभी कभी हो सकता है। समथिंग टू नो इज कि रोडेंट जो होते हैं, रैट्स जो अपने चूहे होते हैं, उनके काटने से ज्यादातर, रेबीज रैट के और रैबिट के, इनके काटने से ज्यादातर नहीं होता है, ये लहरी के काटने से नहीं होता है। और हिंदुस्तान में चिड़िया और बैट, चमगादड़, इसके कैरियर नहीं है। विदेशों में जो वाइल्ड बैट है, व्हेन वी रीड वेस्टर्न लिटरेचर, बैट्स आर अ वेरी इंपॉर्टेंट कैरियर, बट नॉट सो फार इन इंडिया। आई थिंक वी सेड दिस मेनी टाइम्स। एक छोटा सा क्विज सारे बच्चों से, तो क्या करें जब कुत्ता काट ले? पड़ोसी से मिलने जाए, या डॉक्टर से मिलने जाए, या घर में छुप के बैठे? क्या करना चाहिए? जवाब क्या करेंगे? सबसे पहले घाव को धोएंगे। अभी भी जितने भी लोग मेरे पास आते हैं, उसमें लाल मिर्ची लगाते हैं, उसमें मिट्टी का तेल लगाते हैं, उसमें मिट्टी लगाते हैं घाव में। ऐसा कुछ भी नहीं करना है। घाव को अच्छे से चलते पानी के नीचे साफ पानी से धोना है। जो भी साबुन आपके पास घर में हो, उस साबुन से धोना है। यदि आपके पास डेटॉल, सैवलॉन, लाइफ बॉय टाइप का कोई हैंड वॉश रखा है, तो उससे वॉश करिए, या डेटॉल और सैवलॉन का अगर आपके पास एक्टिव रखा है तो उससे वॉश करिए, दैट इज बेस्ट। वॉश इट ऑफ विद रनिंग वाटर, डू नॉट कीप टचिंग द वुंड। फिल्मी तरीके से उसमें से दबा दबा के खून निकालना, उसको सक करना, ये सब चीजें नहीं करनी है बिल्कुल भी। और उसके आगे फिर वैक्सीनेशन करना। तो वुंड वॉश एंड केयर इज वेरी 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 इंपॉर्टेंट। दीस पिक्चर्स आर सेल्फ एक्सप्लेनेटरी कि घाव को अच्छी तरह से धोइए। घाव को धोने का क्या इंपॉर्टेंस है कि जो जानवर का सलाइवा आपके घाव में लग गया था, जिसमें हो सकता है कि वायरस हो, वो वॉश ऑफ हो जाएगी। घाव को आपको कभी भी इरिटेट नहीं करना है, आपको उसको दबाना नहीं है, खून निकालना नहीं है कि गंदा खून है मैं निकाल दूंगा, या उसको आपको स्पिरिट वगैरह इरिटेंट से नहीं टच करना है। व्हाट यू शुड पुट इज अ बीटाडीन सॉल्यूशन और बीटाडीन ऑइंटमेंट आफ्टर दैट। द इम्पोर्टेंट थिंग इज टू आइडेंटिफाई ऑल द बाइट्स। ऐसा नहीं हो कि आपने 3-4 जगह पे बाइट हुए थे और 1-2 को वॉश कर दिया और 1-2 रह गए। नन ऑफ द बाइट्स शुड एस्केप और स्क्रैच। Wash them with soap and water, I already told, and use any antiseptic solution. Then you can go to your doctor and ask for antibodies, that is immunoglobulin and vaccine. So what are the don'ts? कि बैंडेज नहीं करना है, बंद करके नहीं रखना है उस घाव को, और कोई भी उसके ऊपर इरिटेंट नहीं लगाना है। जैसे मैंने अभी बताया, हरी लाल मिर्च और हल्दी, भाई हम सब्जी नहीं बना रहे हैं घाव की, हम घाव को ठीक करने की कोशिश कर रहे हैं। उसके ऊपर प्लीज मसाले मत लगाइए। मसालों को किचन में रखिए। नीम नहीं लगाना है, नींबू नहीं लगाना है, कोई पौधे का जूस नहीं लगाना है, चाय कॉफी नहीं लगानी है, उसके ऊपर पत्ते नहीं बांधने हैं, उसके ऊपर सिक्के नहीं बांधने हैं, और उसको सूचर नहीं करना है। If sometimes this problem will arise, I think couple of months back there was a patient, a staff patient who had a very bad bite, and उसको सूचरिंग की जरूरत पड़ी थी। So हमारे ट्रॉमा सेंटर में उसकी सूचरिंग हुई थी, but that should only be done once the patient has been given immunoglobulin and also started on vaccination. So do not suture the wound. The wound, for the wound you may need oral antibiotics. So talk to your doctor about that. डू नॉट कीप टचिंग द वुंड। ये भी एक बहुत बुरी आदत है हमारे यहाँ के लोगों की प्लीज थैंक यू, ओके, उसको छूते रहते हैं, हर घाव को छूते हैं। आप क्यों बार बार उसको इरिटेट कर रहे हैं? और यदि उसमें वायरस है तो उसको अपने अंदर ट्रांसमिट कर रहे हैं। छूइए मत घाव को। ट्रीटमेंट को बिल्कुल भी डिले मत करिए। और कुछ एरियाज हमारे शरीर के हैं जो नर्व्स में बहुत रिच होते हैं, हैंड, फेस, नेक, तो यहाँ पे बाइट्स पर्टिकुलरली रिस्की होती हैं। सिवियरिटी ऑफ बाइट पे ऑफ कोर्स वो जो है डिपेंड करता है। बहुत बड़ा यदि घाव है और उसके थ्रू नेचुरली ज्यादा वायरल लोड आपके अंदर जाने का चांस है। और जो है जितना ज्यादा बड़ा घाव होगा उतना ज्यादा चांस है, और जितना ब्लड निकल रहा है, स्किन ब्रीच ज्यादा है, तो देयर इज मोर चांस दैट द वायरस विल स्टार्ट ट्रैवलिंग इनसाइड द बॉडी इवन मोर। Likewise, if there are multiple sites of bites or there are bites on fingers and genitalia, again like I said that children get bitten on the face and neck, also on fingers, क्योंकि बच्चे जाके डरते नहीं हैं, कुत्तों के मुंह इत्यादि में हाथ डालने लगते हैं। So उसके बाद आप डॉक्टरी सलाह लें, जिसमें कि एंटी रेबीज ट्रीटमेंट है, जिसके 2 पार्ट है, एक है वैक्सीन और एक है इम्यूनोग्लोबुलिन। ये मैं सबको यहाँ पे बताना चाहूंगी कि वैक्सीन के जो है 5 डोजेस होते हैं. Day 0 starting from the day you go to the doctor, which should be the very same day, at the most the next day. अगर आज शाम को रात को हुआ और आप इमरजेंसी से नहीं लगवा पाए तो प्लीज नेक्स्ट वर्किंग डे पर यू मस्ट गो टू योर डॉक्टर. That is day 0. Count from that. There is day 3, 7, 14, 28. अंदाजन आप समझ लीजिए कि यदि 5 मई को पहली बाइट हुई तो 3 जून को आपका डे 28 वाला वैक्सीन आना चाहिए. इस तरह से आप हमेशा याद रखिए, कोई भी डोज को मिस नहीं करिए. जितने अच्छे से आप वैक्सीनेशन लेंगे उतना जल्दी आपके शरीर में एंटीबॉडीज फॉर्म होंगी, उतने अच्छे से फॉर्म होंगी. दिस इज अ लाइफ सेविंग वैक्सीन. किसी को ये नहीं कहना है मैं मामा जी की शादी में चला गया, मेरे चाचा जी के घर में फला चीज थी. दिस इज अ लाइफ सेविंग वैक्सीन. दिस शुड टेक प्रेसिडेंस ओवर एवरीथिंग एल्स. आपको जो डेट उस वैक्सीन को जिस डेट को देना है उसी डेट को लेना है और हमेशा बाजू में लगना है, कूल्हे में नहीं. तो फिर से एक छोटा सा क्विज हम करते हैं. टीके कब कब लगवाएं? डॉक्टर की सलाह से, या केवल छुट्टी वाले दिन, या आपके पड़ोसी या पड़ोसन आपको जब बोले? बच्चे बहुत इंटेलिजेंट हैं, सब कुछ जानते हैं. चलो, I'm quickly coming to the end of it. So vaccines are the best way to prevent, but sometimes the bite is so bad that we cannot even wait for antibodies to form because of vaccination. In that case, we have to give immunoglobulin. Immunoglobulin से आपको ready-made antibodies तुरंत मिल जाती हैं जब तक कि वैक्सीन टेक ओवर करती है. और इसका जो डोज है 20 इंटरनेशनल यूनिट पर किलोग्राम बॉडी वेट, मैक्सिमम 1500. तो यदि कोई 20 किलो का है तो 400 इंटरनेशनल यूनिट, अगर कोई 75 किलो का है तो 1500, और अगर कोई 80 किलो का भी है तो 1500 इंटरनेशनल यूनिट. जितना हो सके घाव के आसपास देना है. दिस शुड बी गिवन विद इन 2 days प्रेफरेबली, एंड जितना हो सके घाव के आसपास देना है. बाकी का जो बचे वो एक इंट्रामस्कुलर साइट अदर देन दैट ऑफ वैक्सीन पे दे सकते हैं, पर जहां तक हो सके घाव के आसपास देना है. यदि 2 दिन में नहीं दे पाए तो भी कोशिश करें डे 7 वाली वैक्सीन, यानी कि 3rd डोज ऑफ वैक्सीन से पहले जरूर इसको दे दें. उसके बाद देने का फायदा ज्यादा नहीं है, उससे केवल नुकसान हो सकता है क्योंकि वो एंटीबॉडीज के साथ इंटरफेयर करता है. सो जस्ट टू सम अप, द कैरी होम messages are that you should always consult your doctor. Patients should always inform the doctor and their family members of every possible bite and scratch. Even a small scratch will lead to rabies. Please do not ignore. If you are bitten, immediately follow wound washing procedure. Avoid contact with wild animals as far as possible, and do not miss any dose of vaccination. So like I said, just to recapitulate, there are 3 pillars of prevention. Wound management must never be neglected. Please do not irritate the wound. Please लाल मिर्ची, हल्दी, कॉफी, चाय ये सब मत लगाइए. वैक्सीनेशन करवाइए. यदि जरूरत हो तो इम्यूनोग्लोबुलिन लगाइए. Dr. Baranwal already talked about this. There is the motto of mantra of today's times is One Health. So वर्ल्ड रेबीज डे होता है 28 सितंबर को हर साल. तो इसका जो मोटो है वो है 0/30. 2030 तक सभी रेबीज डेथ्स पूरे वर्ल्ड में खत्म हो जानी चाहिए. 0/30. दैट इज द मंत्र. थैंक यू.
Thank you, madam, for your wonderful presentation. Rather, I can say it was a very wonderful teaching. And I, along with many of the audience, remain confused that whether I'm listening to a medical teacher or a school teacher, because your gestures were all full of care with some aggression.
These children are very young. They are like school kids only.
You actually reminded my old days of schools.
I hope you mean it as a compliment.
Ma'am, I had a question regarding this topic.
हम क्वेश्चंस बाद में लें. सब क्या? What do you say? निखिल आप?
Yes, ma'am.
हाँ, we'll take questions in the end. ठीक है. आप मुझे तब तक अपना क्वेश्चन आके बता दो लिखकर, ताकि मैं उसका बहुत मुझे ना आता हो जवाब तो मुझे गूगल करना पड़ेगा. मैंने इसीलिए कहा कि लास्ट में करेंगे सवाल. आप आ जाइए डॉक्टर साहब. ओके.
Thank you, madam, for sharing with us the practical aspects to be followed immediately after bite. Really, it was a very informative session. Not only for the students, even for the teachers also, it was a very useful matter. Thank you, sir, for moderating this session. Now I call Dr. Bishal Gupta, Department of Microbiology, SDPGMS, to talk on scrub typhus. I request Dr. Yeki Baranwal to moderate this session.
हमको पानी दे दो यार, एक बोतल.
So now let me discuss about scrub typhus, which is a very great concern of health economics, but somewhere ignored in our community, in our diagnostic system. So I'm welcoming Dr. Gupta to deliver his talk so that we can have a better awareness about scrub typhus. Dr. Gupta, please.
Thank you, sir. Good afternoon, everyone. Respected faculties, seniors, delegates, and students. Today is World Zoonoses Day. So I am discussing about a very important, also very much underdiagnosed topic. This is scrub typhus, which is very much prevalent in India. So it may be new to you nursing students, but you should know this because as an endemic to India, and scrub typhus caused by Orientia sutsugamushi, a difficult name, and it causes acute febrile illness, which is transmitted by a mite, which is known as trombiculid mite, and it is very much endemic in Southeast Asia. And the term sutsugamushi, if we broke the term, sutsuga means small and dangerous, and mushi means insect or mite. So this Orientia species or Orientia sutsugamushi, it is a bacteria which belongs to family Rickettsia. And according to WHO, this disease scrub typhus, it is the most underdiagnosed and underreported febrile illness in this Southeast Asia region. And recently, after the emerging of the diagnosis in India, after 2014 or 2015, it can be considered as re-emerging disease, which is very much increasingly recognized in India. And it is not a new disease, it's an old disease. During the Second World War, near the Burma, now called Myanmar, there was very much outbreak of scrub typhus, and about 36,000 soldiers were incapacitated or died due to only for the scrub typhus in those days. So this is a triangle which is known as the Sutsugamushi triangle, and one point is from Pakistan or Afghanistan, another point is from Japan, and another is from Northern Australia. And between this area, those the countries are present, their population at risk, and 1 million cases occurs annually in this region. So what is the vector of this scrub typhus? This Leptotrombidium species, and in study they found that in Gorakhpur and Pondicherry, Leptotrombidium deliensis and other like Ornithonisus and Leptotrombidium jayavikrami and Rajasthanisi, they are very much prevalent as a vector. So this is a mite-borne infection, and the reservoir are, one is the mite itself as a reservoir, and which is the most common, that is the rodents. The rodents are very much prevalent in all the areas in everywhere in the country. So actually what happens, the rodents or rats, they carry the mites and they transmit the infection in here and there. And it was first reported in Japan. And why the scrub typhus? So why the term scrub? So scrub is a type of vegetation, bushes. So grassy lawn, जो SGPGI के अंदर बहुत कॉमन है, बुशेस, छोटा छोटा जो पार्क जो है, बहुत सारे बुशेस होता है, तो that may be a source of infection, where the chiggers, that is the juvenile form of the mite, that remains intact, and they accidentally comes to the human contact. So how the clinical manifestation presents? It's a febrile illness, so fever to hoga hi hoga. So incubation period is 5 to 21 days, and what is interesting that those mite, it comes contact with the human skin after the initial bite, a papule or small lesion is developed at the site of the bite, which ulcerates and heals with development of blackish area, which is known as eschar, which is very much pathognomonic of the scrub typhus. So these are the various form of eschar which I have encountered in my previous institutes. What one is important thing that the eschar is to be seen in various sites of the special. खुले जाएगा नहीं मिलेगा तो एस्चर, जो धक्का रहता है उस जगह ही मिलता है एस्चर, लाइक द ग्रॉइन, एक्सिला, जेनिटलिया और नेक, जहाँ पर छुपे रहते हैं वो माइट, वहीं पर ये वो एस्चर मिलेगा, वहीं पर हमें देखना है, ढूंढना है, ढूंढ के निकालना पड़ेगा। कोई पेशेंट अपने नहीं बताएगा कि यहाँ पर हाँ मेरा एस्चर हुआ है आप देख लीजिए, ऐसा नहीं होगा। फीवर विद दिस टाइप ऑफ लेशन ऑलवेज सस्पेक्ट scrub typhus. And other eschar-like lesions should be ruled out, like spider bites, insect bites, scab due to trauma, other spotted fever, and also most importantly anthrax. And fever और ये eschar के अलावा और ब्रैडिकार्डिया होगा, हेडेक, मायल्जिया, एपैथी, लिम्फेडेनोपैथी, फोटोफोबिया, ड्राई कॉफ, ये एक मल्टी सिस्टम इन्वॉल्वमेंट डिजीज है, तो हेड से टो तक सारे ऑर्गन इन्वॉल्व हो सकते हैं। So, and approximately 1 week later, a spotted and maculopapular rash appears first on the trunk and then extremities, which blenches within a few days. What are the complications of scrub typhus? तो बहुत सारा complications हो सकता है, even ये complication fatal भी हो सकता है। Interstitial pneumonia is the most common. Around 30 to 65% of the cases may develop if untreated. Interstitial pneumonia in various studies. meningoencephalitis हो सकता है, myocarditis हो सकता है, acute renal failure हो सकता है, और इसी से mortality rate 30% तक हो सकता है अगर untreated रहे तो हमें diagnosis करना है। तो laboratory diagnosis कैसे करें? सीरम से करना है, most common जो हम लोग करते हैं serological test, particularly IgG और IgM. So presence of IgM antibody indicates the recent infection, and IgM antibody titer should be observed after 5 or 6 days, end of the first week, and IgG appears end of the second week. And जो ELISA का जो OD वैल्यू है, मतलब ऑप्टिकल डेंसिटी वैल्यू, वो इम्पोर्टेंट चीज है, क्योंकि उसी के हिसाब से कट ऑफ निर्धारित किया जाता है। तो अभी इंडिया का कट ऑफ CMC वेलोर ने एस्टेब्लिश किया था, जो था 0.5। अगर 0.5 के ऊपर कोई एलाइजा का रीडिंग आए स्क्रब टाइफस का, तो ये पॉजिटिव दिया जाता है। लेकिन अभी जो रिसेंट गाइडलाइन बोलते हैं कि 0.5 to 0.1 इज ग्रे जोन। अभी 1 अगर ओडी वैल्यू 1 से ऊपर हो तो भी इसको प्रॉपर स्क्रब टाइफस इन्फेक्शन हुआ है ऐसा माना जाता है। और वो भी इम्पोर्टेंट है, तो कब टेस्ट करना है? अगर लेस देन 5 डेज में आप सस्पेक्टेड स्क्रब टाइफस कर रहे हो सस्पेक्ट, तो उसको IgM एंटीबॉडी देखने से कोई फर्क नहीं पड़ेगा, क्योंकि उनमें IgM एंटीबॉडी आने में 5-6 दिन के बाद आता है, तो लेस देन 5 डेज में नहीं आएगा। तो तब लेस देन 5 डेज में अगर डायग्नोसिस करना है तो तब मॉलिक्यूलर डायग्नोसिस में हमें जाना है। और क्या क्या टेस्ट? अभी वेल फेलिक्स टेस्ट ये पहले होता था, अभी यूज नहीं होता है, ये हिस्टोरिकल ये चीज है। वेल फेलिक्स रीजन में प्रोटियस का स्टेन लेकर उससे अगेंस्ट एंटीबॉडी टाइटर किया जाता था, लेकिन अभी इसका यूज अभी नहीं होता। और जो गोल्ड स्टैंडर्ड है वो है इम्यूनोफ्लोरेसेंस से इनडायरेक्ट आई, तो उसका हाई सेंसिटिविटी है, लेकिन वो बहुत एक्सपेंसिव है, इसलिए अभी तो नहीं होता है। और रैपिड टेस्ट होता है जो लेटरल फ्लो ऐसे की तरफ होता है, उसमें IgG और IgM दोनों ही डायग्नोसिस कर सकता है, which is easy to perform and it gives results about 10 minutes. बट रैपिड डायग्नोसिस रिजल्ट से अगर पॉजिटिव आया तो ठीक है, पॉजिटिव मान लेंगे, लेकिन नेगेटिव आया तो यू शुड रूल आउट विथ serological test like ELISA. And molecular diagnosis by Orientia gene, 2 types of gene, 46 kilorandton or 47 kilorandton or 56 kilorandton, they have the antigen. And वो जो एस्चार्ट था एस्चालिसन, उसी के मटेरियल से अगर किया जाए तो ये सबसे इम्पोर्टेंट मटेरियल होता है, मोस्ट सेंसिटिव मटेरियल होता है। अगर ब्लड का यूज करें तो बाकी कोर्स से हम लोग ये मॉलिक्यूलर डायग्नोसिस कर सकते हैं, लेकिन इसके ये बहुत एक्सपेंसिव है और इसके लिए ट्रेन स्टाफ की भी जरूरत है। और हमारा यहाँ पर SGPGI में स्क्रब का एलाइजा होता है। और ये एक दिस इज अ स्टडी, दिस वाज डन इन CDC NIMHANS under CDC NIMHANS project. There are 5 medical colleges, 5 institutes, not medical college, 5 institutes which are included in this study. And this study showed that among the acute encephalitis syndrome cases, the most important causative organism in all over India, वैसे ही 3 or 4 states में किया गया था, is scrub typhus, around ranging around from 20 to 33% are causative by causative agents are scrub typhus. And this is a study from SGPGI, our SGPGI, and where the pyrexia of unknown origin, the study was conducted, where the 3-year study period from 2017 to 2020, among the PUO cases, 18.6% were due to scrub typhus, only second to enteric fever or typhoid. This is from my previous institute. This was one about the pyrexia of unknown origin, AFI case, acute febrile illness cases, where about 34% cases were due to scrub typhus, and among the AES cases, acute encephalitis syndrome cases, about 30% are due to scrub typhus. And one important thing is noted that the monthly distribution. There are 2 peaks of scrub typhus in India. One is monsoon, another is post monsoon. ये जो पोस्ट मानसून वाला है ये बहुत भयानक होता है। जब मानसून खत्म होता जा रहा है, यानी कि अक्टूबर या नवंबर में, तब सबसे ज्यादा स्क्रब टाइफस का आगमन होता है। This is I got a news from the Kerala that death occurs due to scrub typhus in a child. It's very unfortunate that in era of doxycycline, the death due to scrub typhus is occurring. But anyways, in adults, the doxycycline is the drug of choice, 200 milligram per day in 2 divided doses, and alternative is azithromycin. In children, also doxycycline can be used, 4.5 milligram per kg body weight, and azithromycin can be the alternative. But in pregnant women, doxycycline is contraindicated, so azithromycin is the drug of choice, 500 milligram single dose for 5 days. So what is the key messages? So always consider scrub typhus in the differential diagnosis of sepsis, fever with rash, fever with altered sensorium, fever with myalgia, fever with jaundice, and always rule out scrub typhus from any diagnosed cause of fever like dengue, malaria, enteric, leptospira, because doxycycline is a magic bullet. बाकी सबका फीवर का ट्रीटमेंट है कि नहीं, लेकिन ये स्क्रब का ट्रीटमेंट है। फीवर डॉक्सीसाइक्लिन देंगे तो पेशेंट 2 दिन में, अगर किसी AES पेशेंट को हुआ तो 2 दिन में वो चंगा हो जाता है। और हिस्ट्री टेकिंग इज वेरी मच important. Any recreational activity prior to the onset of symptoms should be given rise to suspicion of the scrub typhus. And also always rule out the cross reactivity. Don't overtreat scrub typhus. It's better to ask the OD value in case of scrub typhus positive cases. And always convalescent sample should be asked or check the rising titer for the confirmation of the cases. ये सभी ELISA या serological test का वो होता है. So what is the conclusion? That scrub typhus is a re-emerging acute febrile illness and also cause of acute encephalitis syndrome with non-specific clinical presentation and can be cured completely with adequate and proper treatment. And early and proper diagnosis can prevent the development of the undue complication and reduce the mortality. So this was the talk, and thank you.
Thank you, Dr. Gupta, for such a huge, vast, detailed information, discussion, and teaching. And actually, he is having double experience, SGPGI as well as Institute of Tropical Medicine, Kolkata. He is so experienced. In summary, I'll say he shared the lines of Scruff Typhus Bible. Thank you so much.
Thank you.
Thank you, sir, for enhancing our knowledge with detailed explanation with both clinical as well as research findings. Thank you, Baranwal, sir, for moderating this session. Next, I would like to invite Dr. O.P. Sanjeev, Associate Professor, Department of Emergency Medicine, to speak on emergency management of zoonosis, lessons from COVID pandemic. He was in STPGMS as a senior resident for 4 years. Then he was appointed as an assistant professor in AIIMS, Patna, for about 6 months. He has published total of 32 research papers and also presented his research papers at different levels at state, national, and international level. From 2018 onwards, he is working as an associate professor here. Now I invite him to speak on his topic. I request Dr. Prerna Kapoor to moderate this session.
Thank you. First of all, a privilege to listen to and moderate a session by Dr. O.P. Sanjeev. Dr. O.P. Sanjeev, I'm sure कि सब लोग जानते हैं. He is a very, very busy consultant in emergency medicine department, and he did a whole lot of very good work in COVID times, and even in non-COVID times, he remains occupied with lots of clinical and academic work. And this is the first time actually I am listening to a academic talk from Dr. O.P. Sanjeev. मैंने बाकी वाले वो ethics वाले sessions सुने हैं. So I think I'm as excited as everyone else is to listen to Dr. O.P. Sanjeev.
Thank you. Good afternoon, one and all. Now let's come to the topic. The topic allotted to me is emergency management of zoonosis, lessons learned from COVID-19 pandemic. Let's first think that COVID-19 is really a zoonotic disease, because currently the zoonotic source of SARS-CoV-2 virus is still to be confirmed. And evidences from survey and targeted studies so far has shown that coronaviruses like SARS-CoV-2 that causes COVID-19 do not match completely coronaviruses which are present in reservoir hosts like bats or pangolins. So till now, the spike protein of the coronavirus had much similarity with those of coronaviruses of bats or pangolins up to 99%, but the complete genome sequencing from the human sources, it matches only up to 92 to 93%. So with the much confirmation, I cannot say that COVID-19 is a zoonotic disease. And the WHO task force has worked much in Wuhan, Hubei, to find out actually the origin of the coronavirus SARS-CoV-2, because initially there was a news in media that the virus had jumped out of the lab, but probably it has been ruled out. The virus must have been jumped from the reservoir host like bats or pangolins to the human beings, but still the confirmation is to come. So on the World Zoonosis Day, let's celebrate it like a zoonotic disease. So emergency department, whenever a new challenge comes to the healthcare segment, emergency becomes the biggest sufferer, because the other professionals, other departments have some options, some excuses that you can call me, I will prescribe treatment on your WhatsApp, or you are all well, you keep monitoring everything. But when he or she falls sick, he or she will definitely report to emergency department, because everyone knows that the doors of the emergency are open 24/7 for 365 days. So anyone at any time with any disease can come to emergency, and we cannot deny providing the treatment. So the latter part of my topic, that lessons learned from the COVID-19 pandemic. The first lesson I can share with you all, that we need telemedicine like services or emergency medical services in our country like Europe and USA. Because I have observed that most of the senior faculties of SGPGI were engaged and occupied addressing the calls of different patients and different segments of the COVID-19 management system. Even senior professor of age 60, 62 were attending calls like anyone, like call center respondents. So we definitely need a telemedicine like system or emergency medical services in the country. We need integration of intensive care facilities. We have different sets of doctors and nursing staffs or other paramedics which are working in different ICUs. Like some of the nurses are working in neurosurgery ICU, some other are working in pulmonary medicine ICU, some in critical care ICU. A group of people are working in emergency medicine ICU. We need an integration of all those so that we can bring them at the same level and the same platform. Training of life-saving therapies, life-saving skills to everyone, right from the professor to the hospital attendant, to the ward attendant, everyone. We had a very bitter experience during COVID-19 that most of the nursing staffs who had not worked in ICUs or emergency setting for more than 15 years. They have acquired skills in OTs and some other center, but they are not well versed with treating the patients who require oxygen support or life support. Similarly for the doctors, there are many surgical doctors who refuse that I don't know how oxygen is supplemented, how rate is selected, how device oxygen delivery devices are selected. So definitely we need to make a common platform to train all of them, means all doctors, all nurses, all technicians, the life-saving therapies. It must be a part of routine teaching and routine working in our hospitals. A surge congruent ED. Now I am coming to emergency department. Emergency department has always a limited number of beds, but we need to create an infrastructure that must be surge congruent. You can see the left side photo, that is probably a waiting hall. In every area of emergency department, every floor, even waiting area, we can mount oxygen pipeline so that in emergency we can easily expand our beds, oxygen beds in fact. Infectious disease triage in emergency department. We ED physicians always triage according to the hemodynamic and oxygen requirements of the patient. That is, you are in the emergent need of healthcare. You are not in emergent need, rather you are in urgent need, so that you can wait for 3 to 4 hours. And some patients are purely cold elective and we refer them to OPD. But we never triage a patient in view of infectious disease. It is only COVID-19 which gave us as a lesson that every fever patient must be triaged separately and segregated from the rest of the patients. So ID triage is a must for the ED. Quality-driven ED care. We must ensure infection prevention and control. Emergency is no excuse for putting infection inside the patient's bloodstream. This is not that we are working in emergency so we can insert a central line or a peripheral venous catheter like anything. We have to exercise all in infection prevention control practices while we're dealing with the human life. Timely care, patient-centered care. This is not that we doctors know everything about a patient. No nursing staff knows everything about the patient. We must be patient to listen actually the words of our patients and their relatives, because they know much more about their disease, because they are the sufferer. We are here to treat them. So we must be patient enough to listen their words. We must speak politely, humbly, and we must acknowledge, address their queries and apprehension. Thereafter, our medicines will work. Otherwise, our antibiotics will never work. And we need to give a comprehensive, effective care. Thank you very much.
That was a very excellent talk, Dr. OP Sanjeev. बहुत बार पिछले 2 सालों में सबने इस बात को दोहराया कि कोविड हैज बिन अ वेरी बिग टीचर, और कुछ कोविड ने हम लोग को एक्सपीरियंस कराया हो या ना कराया हो, बहुत चीजें सिखाई, बहुत से नए तरीके हमने रहने के सीखे और चीजों से डील करने के सीखे। तो डॉक्टर ओपी संजीव ने कोविड टाइम्स का अपना पूरा सार हमें आज दिखाया कि कोविड ने इमरजेंसी मेडिसिन और डॉक्टरी में क्या क्या हमें सीखने पर मजबूर किया, और जिन टीचिंग्स को हमें शायद याद रखना चाहिए। क्या पता कि ये जमाना ऐसा आया है, कब कौन सा पैंडेमिक आए, कौन सा जूनोसिस आए। सो वी शुड ऑलवेज बी रेडी। पुरानी टीचिंग्स को हमें भूले नहीं, इसके ऊपर हम हमेशा बिल्ड करते रहे। सो देन वील हैव अ बेटर मेडिकल फैसिलिटीज ऑलवेज। थैंक यू डॉक्टर संजीव।
Thank you, sir, for sharing a valuable wisdom with us. It will definitely help us in future career. Thank you, ma'am, for moderating this session. Next, I invite the speaker, Mr. Digil CD, Quality Nurse Coordinator, Hospital Administration, to talk on monkeypox. I request Dr. OP Sanjeev to moderate this session.
Nikhil is my friend, and it is pleasure for me to say a few words in public for him. He is really an important asset for the nursing cadre of this institute, no doubt, but rather I can extend to say that he's an important asset for this whole SGPGI. We need such dynamic people in our SGPGI at all cadres so that we can work enough to take this institute to a new height. Actually, जो PGI ने अभी तक अपना reputation बनाया है, उसके तो अभी हम लोग मजे ले रहे हैं। हमने तो कुछ खास किया नहीं है, पर PGI के चलते हमें भी लोग इज्जत करते हैं कि भाई PGI के डॉक्टर साहब हैं या PGI के नर्सिंग स्टाफ है। लेकिन अब जो जरूरत है, जहाँ पे PGI के पैरेलल में बहुत सारे इंस्टीट्यूट्स हैं, लाइक KGMC, राम मनोहर लोहिया, they are also working excellently. So we need to achieve a different height, a different horizon actually, to set another example for other institutes to come in our companies. So I welcome Nikhil and invite you to begin your talk. Thank you.
Thank you. That was really kind words from one of the stalwart, I would say, because I have seen you working, sir, in the COVID time, more or less 24/7 for all those, like first wave, second wave, third wave, and numerous things. Thank you so much, sir. Thank you so much. So coming to the talk, I'm going to have a bullet train, because within 10 minutes, I have to complete something which is not there in India. That is the monkeypox. In 2019, December, we were thinking that we won't have COVID in India. Later, when I was going back to Kerala, the first COVID case reported in my own district. And we all were in shock, because by then people were dying horrifyingly in China. So right now, the condition is this, that it is spreading like anything in Europe. More than 54 countries are affected right now, and it is keep on spreading. And good part is that the mortality is less, but we don't know how the mutation of the virus will go ahead and take its course. So let's move into the basics of monkeypox here. So you can see the picture how it will look like. This is as most of the people who is in this room would have never seen any patient with the smallpox. So this will be little, fresh for all of us. So it is a virus infection, infection by monkeypox virus, typically self-limiting, but can lead to severe illness up or death. Death occurs up to 11% of cases. So zoonotic transmission, it is primarily found in Africa, around the rainforest. Natural host is unknown. Many species of small rodents, what we also find all around our, this environment is, susceptible to monkeypox virus. So following eradication of smallpox, we don't use the vaccines anymore, so that we all are very high risk for this virus if it comes to in India. So speaking about orthopox virus, we have cowpox virus, variola virus. Variola, we all know, because smallpox. Monkeypox virus is a species of orthopox virus and pox viridae family. It is a clear zoonosis. It is transmitted to humans from animals, and symptoms are more or less like smallpox, although very less severe. So that's about it. You can see the picture of smallpox there, which we have captured using electron microscope. Now, coming to the division, there are two divisions of it. We call it as clades. One is Central African clade and another one is West African clade, where Central African clade, which began in the country of Congo, is very dangerous. It causes more than 11% of the deaths, whereas in opposite West African case, that is primarily from Nigeria, it caused very less severe infection and very less deaths also in that case. You can see a monkey there, but monkeypox virus, it is like an allegation on monkey. Monkey is not the natural host. Monkey is just like a victim like us, but it has come. We identified it in monkeys, so we call it as monkeypox. So you can see the geographical distribution when we had the infection in 2016, but this has totally changed now. Now it is more in this area. All the European countries, especially UK and Germany, have the largest number. And World Health Network, not World Health Organization, they have already declared this as a pandemic. And in coming days, we can expect WHO also take this very seriously and declare as a pandemic. So this is one of the animal you all will be knowing about this. So this can cause this giant poached rats, rope squirrels. I will show you the picture in the coming slides. Infection results from direct contact with the blood, body fluids, or external lesion of an infected person. Eating inadequately cooked meat or infected animals is a possible risk factor, and most of the cases, the source is unknown. You can relate this picture, right? Many animals you would have seen. These all can harbor the virus. Now, how it is transmitted in human to human? It is by close contacts. So one get in family, it is high likely that others may get, and respiratory droplets and skin lesions and contaminated objects can cause this infection. Healthcare workers, once a healthcare worker died when caring for this patient, then the whole attention went to understand that this disease is not something to be neglected. This is very dangerous. This was a history what we had in 1970. Human to human transmission is very limited, but still very dangerous. You can see this small baby, small kid, I would say, with the rashes of this one. Incubation period is 6 to 13 days in most of the cases, but it can go to 5 to 21 days. So we fix it for 5 to 21 days. And the disease course, this after once the symptom starts, the invasion period is 0 to 5 days, which is characterized by high fever, headache, lymphadenopathy, which is a classical symptom of this, which we didn't had in the smallpox. So back pain and myalgia and fatigue, these are the common symptoms. And after that, after these 5 days, the characteristic rash formation will go, and that too in a systematic way it goes. So we can identify this disease clinically by using this movement, this course of these rashes, that is from macules, what is flat lesions, and then to papules, slightly raised lesion, then to vesicle, which contains fluids, and then to pustules, which have pus in it. And later, when it sheds, it becomes crust. And when the crust shuts down, new skin is formed. And once the new skin is formed, this infection is no longer transmissible to another patient. But at the same time, when this affects the various body structure of the human body, it can lead to various complications, and this can lead to the death of the person. And face, it is 95%, and sole and feet of the patient. This is again a classical symptom. No other viral disease, which is relatively, near to this disease doesn't cause this. If the rash is there in hands and sole of the foot, you can identify this may be because of the monkeypox virus. And the most dangerous one is if it affects the conjunctiva. Especially children, this get affected. And when we have this disease in the cornea or in the conjunctiva, the vision gets impaired, and this leads to the blindness. And as this is more in children, and if it is neglected, this disease makes a big, problem to that community entire itself. So it is vital to take care of this. So you can see how, the symptom is shown there in that picture. Now, the differential diagnosis is between three diseases, that is chickenpox, varicella, measles, and smallpox. And we will just see how different these three here we have. Monkeypox fever, we cannot differentiate much, but rash appearance, as I said you, it is macules, papules, vesicles, pustules, and then crust. This will follow a similar pattern. And once the patient is in one form of this rash, the entire body will be having only that kind of rash. Not unlike, chickenpox, where you can find one macule in one part of the body and a papule in other part of the body. This is not going to be like that. Entire body will have one kind of rash, and rash development will be very slow, and rash distribution will be more on the face and on the extremities. And death up to 11%, which is very concerning, and that too with the concoclade. And laboratory diagnosis, we have different stages. We have to go for different diagnostic measures. I'm not going to get into that, but I can say you the confirmatory diagnosis of this disease is using PCR, and other tests, antigen and antibody tests, are not so conclusive. We can say it may be a possibility of any series of this virus, but we cannot say confirmative diagnosis in this way. And as I told you, in incubation period, there is no point in testing. You cannot find out. In the febrile stage, when you have fever, you can take tonsillar and nasopharyngeal swabs. PCR, COVID has taught us lot of us about that, how we have to take that, and all of us in this room have gone through at least one time RT-PCR test. So the procedure is almost same. You have to follow 3 packing system, and then to transport at 4 degrees centigrade, so that the things will not get disturbed. And in rash stage, you have to go for the symptom lesion sample. You have to take. You have to cut down the rash, and from there the sampling need to be taken. And again, you have to follow this three layer package system, and then you have to transport to the laboratory. And in the recovery stage, you can go for serum antibody detection methods. And PCR is the most conclusive, this one. And infection prevention control, again, we all have gone through many training in this. All thing you have to follow is, first one is standard precaution. You have to wear gloves, you have to wear all the personal protective equipments. Then you have to go for contact precaution. You have to wear a gown so that you will not touch and get the disease. And droplet precaution, you have to maintain a social distancing of minimum 1 meter without doubt. and ensure safe and dignified burial also, because customs and traditions vary everywhere. And how we can reduce the human to human transmission. One vaccine is already approved in 2019. If somebody already diagnosed with this disease in a family, the other members of that family can be given with that vaccine, but it is not very common like, Covaxin or Covishield. But if it comes into that level, maybe some of the big corporate people will take initiative to generate that also. Avoid close contact and use all the infection prevention and control strategies. Now coming to the same only, there is nothing much in this trade. Now, how you will manage the patient? There are no specific drugs available to manage this monkeypox as of now, although clinical trials are undergoing. All you have to do is clear symptomatic management, and the symptoms we all know what is going to happen. You have to manage fever and pain, skin, eye, and mouth care to prevent complication, respiratory care, hydration, nutritional support, mental health support, which we have identified in COVID time. How many people suicide? How many people had the mental breakdown? So we have to take care of this also, because they will be on isolation totally. And infection prevention and control should be followed, whether it is in institution or whether it is in home isolation. So what you will do in fever and pain, the external cooling and antipyretic like paracetamol. And skin care, you have to avoid touching, gentle washing, keep clean and dry, protect hydration. In this case, I missed to tell a symptom that this rash can appear in the mouth also, and in the gastrointestinal tract also, especially in the lower area. So what will happen means the patient, especially the children who will get affected, will not drink any fluid or take any nutrition with this. So because of that, what happens means dehydration and nutritional imbalance results, which aggravates all the complications what is arising out of this disease. So this need to be taken care very importantly, and you have to give saline gargle as much as you can give, maybe 4 times a day, so that the patient feel better about himself to take some fluid. This is about mouth care, what I said right now, and vitamin C can add on, multivitamins also can add on, and eye care, you can see how it looks when it goes for this. And in African case, we have a lot of vitamin A deficiency because of already they are not having enough food to eat. So what will be the case when you had that disease? So vitamin A and its prophylaxis will be added advantage. Respiratory care, this can lead to bronchopneumonia also, which can cause all the problems and respiratory failure, and eventually lead to ventilatory care and death. So you have to take care of this. Rehydration therapy, as I told you, nutrition support also will be very much needed. Mental health and social support, and this you can check in WHO site. What are the specific drugs also you can give? It is already described by them. I'm not going to read out here, but this is how it moves on. And coming to complication, we have so many complications. As I told you, it can affect eyes, it can goes to lungs, pneumonia, it can cause skin compromise. The discoloration of the skin can come even after recovering from the disease, and sepsis can occur, and that can lead to the death of the patient. So all these things can happen. Now coming to the community part. When you have a disease, how you will go about the surveillance? Because nowadays, as our topic itself suggests, our topic is on One Health approach. One Health approach means it is the association of the medical people along with the veterinary science doctors with the environmentalist, because all the zoonosis disease have this triad running. And when these 3 type of professionals collaborate to find out the problem and to find the solution, then everything gets solved. If not, it is very difficult. So this is a very evolving concept of One Health for all. So this we need to take up for upcoming other zoonotic disease also. And this is how you have to manage in community. First, you have to report to authorities in whichever level you are, especially for as nurses are now being taken into community health officer positions, you have to report and take it as into more community point of view. Now confirm the outbreak by, getting it tested by PCR test, and convene a multidisciplinary team. Develop a clear case definition about the disease specific to community, and then do the contact tracing to identify all the cases, describe and analyze the data, conduct special studies, and communicate the result to all over the world so that somebody's life in somewhere will be rescued. Now, so almost same only, this is how we have to go about the outbreak response. And about prevention, there are a lot of stigma associated with the disease. Anywhere when this breakout happens, there will be a lot of stigma. You have to break down that stigma and give right information to that community so that you will get better cooperation from that community and it will not spread all over the world. Wear gloves and other protective clothing every time. Avoid close contact. If possible, stay 1 meter distance. And as being nurses more in this group, when you are about to care, do not spend more time with the patient, or try to do the things which you are about to do the patient in a quick span of time, and try to remain 1 meter distance from the patient. This is how you have to do about this. Now, about implication of global preparedness, WHO is doing all the good works and they are trying to make the vaccine as readily available to all of us. So that's all about the monkeypox. All thing I would like to emphasize here is it can come anytime. It can come. People from UK transport to India. People from Germany comes to India. And if somebody comes here and give us the disease, it can spread like anything. And if it comes and go to any of our animal field, then the risk will be more. Thank you so much.
Thank you for your wonderful, comprehensive, and very informative presentation. Thank you very much.
Thank you, sir. Thank you, everyone.
Very nice.
Thank you, sir, for enhancing our knowledge by your vast wisdom in a simple and most effective way. Thank you, Sanjeev, sir, for moderating this session. The last speaker I would like to call is Mr. Yaditya, lecturer at College of Nursing, STP-GMS, to speak on the most important part of this zoonotic disease, that is nursing management. Sir has done his master's in community health nursing. He has nearly 20 years of professional experience. He also has attended many conferences as moderator, delegate, and resource person. I invite him to take over the podium. Also, I call Mr. Upi to moderate this session.
Professor Yaditya, I have known him for quite a long period of time. He is a wonderful person. From the time when he was in Bangalore in 2014-15, I know him. He is a very famous person, especially in the community arena. He will be talking us through the nursing management of zoonotic disease in the changing time. I welcome you, sir.
Thank you, Nikhil. Good evening, everybody. So I'm going to talk about the nurse's responsibility in general, not in specific, because most of the speakers have spoken the specific management part of it and with related to that particular diseases. So I just wanted to run now because everybody is waiting to move from here. Anyway, so with the launch of a new Government of India initiative, Ayushman Bharat, the envisaged conversion of all sub-center into health and wellness center, the role of nursing professional in primary healthcare will be undergoing paradigm shift. So we see here, because of the Ayushman Bharat introduction, so a lot of changes have come in health system, because the sub-centers are being converted into health and wellness center, and where you all know that the CHO will be the head of that particular health center, especially at the sub-center level. Okay, if it is at a PHC level, of course, the medical officer will be available. And if it is in sub-center, the CHOs, community health officers will be available, and the courses are running. And our PG also is a that course. So nurses are approximately 2/3 of the population of health workforce in India. You all know that. And nurses' scope of work has widened with the additional roles and responsibility due to shift of the pattern of the burden of disease, especially with regard to this lot of zoonotic diseases. And one burning issue which we are seeing in front of us is pandemic. Okay, that is COVID pandemic. And emergency of zoonotic infection disease has further enlarged the responsibilities of nurses, and nursing care is the backbone of health system, as you all know. The role of nurses in primary healthcare, especially I'm going to talk about the preventive aspects of it. Okay, so because more than curative, the preventive aspect of care is very important, because most of the nurses, and especially been concentrated now, healthcare delivery system also is concentrated to the village areas, okay, and grassroots areas, where a lot of problems are existing, and where 80% of the population are living in semi-urban and rural areas. Okay, only 20% population are staying in the urban areas, where 80% of the healthcare facilities are available. So that's why the government has taken an initiation that health for all by 2080. So that has again extended to now the next till 30th, 2030 also. So many goals are there. I'm not going to discuss all these things. So here it includes the promotion of health and the prevention of illness and the care of ill and disabled and dying. So it all, there's nothing but a comprehensive care has to be given by the community health nurse, in fact. And the life expectancy at birth improved in India from 59.7 years in 1990 to 70.3 years in 2016 for females especially, and from 58.3 years to 66.9 years for males. We see that lifespan is less in men than the women, because so men are very much involved in external environment works and been with the animals, and also the prone for infection in outside world. So in Indian scenario, if you see, there are been emergency of new and re-emergence of earlier seen infection disease in more virulent form after a period of decline in or disappearance. So it disappears and again it rises up. Especially we see in 1993, I believe. So there was a outbreak of plague in North India, especially. So we were about to come from South India to North India for a tour because of that plague. Okay, which is the carrier of that plague virus is rat. So now it is not there. Okay, so suddenly we don't know when it is going to rise up. So the role of nurse has consequently further expanded to keep the public informed about these infectious diseases and risk involved, while at the same time working towards the prevention of the spread of disease. It is very important for the community health nurses to have a proper health education programs. So I am the community health nurse specialist, okay, and I take students to the community, and most of our students, they are come there. I think they had a very good session of health education there. So we also should give importance to these zoonotic diseases in future. Okay, so there is in Shishandi, we see that I see that there is an veterinary hospital, government veterinary hospital. I went to the doctor and I requested him, sir, can you give a lecture for our student at least for an half an hour? Okay, sir, we'll give, but he could not make the time. Okay, because maybe because of negligence. I feel most of the time they used to sit quiet and they used to have nice tea and snacks and all. So they say, no, wo program hai sir, ye program hai, dekhenge aage. So that made me not to go and approach them again. So that's what we need to again motivate them and involve them. So as the main focus of this is, it is One Health. So One Health includes nurses, also doctors and veterinary scientists, okay, and the other lay people also, because they are the one living with the animals and using them for a different purpose. And auxiliary nurse, ANMs, and also LHVs and ASHAs are the grassroots level workers. We need to educate these people and supervise these people as a CHOs, community health officers. You are going to be going to take a position in future, I hope, because many opportunities are there, community-based opportunities are there for the nurses. So you should strengthen these three people, three cadres. That's what I'm telling you. I'm talking in general, not in specific about it. Okay. So for that, you need to have a lot of information about the zoonotic diseases. Of course, I'm not going to deal this slide because it consists of a lot of how many numbers of LHVs and ANMs are there. So time constraint. And even this also I'm going to, just I wanted to mention here, the people who are at risk. So very young and elderly, immunosuppressed, compromised people, and pregnant ladies, and also who have injuries more susceptible to infection, and especially the people, those who are working in the farms. Okay, so farmers, they are prone to get a lot of insect bite, animal bites, and a lot of contact with the animals, and they also use the cow dung for many purposes, and it harbors a lot of microorganisms, especially Clostridium tetani, which causes tetanus, is very rich in cow dung. And they work in the field, they also get cut in their fingers and in their legs, but still they're forced to do that work because it is inevitable. And as a community health nurse, and it becomes a great responsibility for you people to go to their doorsteps and educate them about the different zoonotic diseases which are present or prevailing in the society. Okay, so again, we see here sub-centers are being upgraded as health and wellness center, where very less importance is being given for the zoonotic diseases, because I take students for the visit to the sub-center, especially Jabroli sub-center we take. So there also we have a CHO. But when I heard about the responsibilities, I never heard any responsibilities towards zoonotic diseases. So that means there is a need to bring some revival in the curriculum and also in the practices. And several, this is, okay. So there are some challenges we can see. So several factors related to availability of infection disease knowledge. So it's very important. That's why we organized this session today, to give some information to you people. And I'm so happy that very informative lectures were there today. And external environment, how our environment also has an impact on the zoonotic diseases is very important. And the work environment influence the effective participation of the public health force, that is nurse, in zoonosis surveillance and prevention control. The number of veterinary hospitals in India is 11,367 of March of in the March according to the March 2015, and their availability and access in rural areas very, very poor. That's what I said. Okay, so many hospitals we can see, but veterinary hospitals are very few. And here also we see veterinary hospital, especially we see hospitals for pets, not for the other animals, only pets, that too dogs especially, and cats. Okay, so we need to come out with the many such centers. I'm just going ahead. And healthcare providers, physicians, clinics, and hospital generally base the information of zoonotic infection on notifiable reports for effective surveillance record of patient, hospital, laboratory, and death records also need to be included. Okay, so what for the deaths have happened? Okay, the cause of death also is very important. Okay, so because of that, and this review, we can anticipate how serious the zoonotic diseases in our society, our community. So a dedicated epidemiological investigation to measure the morbidity and mortality impacts of specific zoonotic diseases at community level, together with their seasonality and geographical location and other risk factors need to be carried out. So collaboration between the veterinarians and health providers, nurses, policymakers, and environmentalists is a joint surveillance approach called as One Health. That's what Mr. Dikil also has discussed about that. So in conclusion, I don't want to just read this and just wanted to come to a last point and just wanted to say that, so especially as a community health nurses, make sure that, so it's very important to educate the people. Okay, education is the backbone of the health care delivery system, I can say. Okay, so make sure that the person who is handling is vaccinated, okay, against certain diseases which are available, the vaccines are available, and the animals which they are handling, they are vaccinated properly. Nowadays, if you see in the community area, so you can see the cattle with a yellow color badges in their ear. So that indicates they are vaccinated. Okay, and dogs, pet lovers, they should vaccinate their dogs periodically every year. Okay, I already told that I'm a pet lover, dog lover. I suffered a hydrated cyst. Okay, still I have a dog with me, right? So, but you should be very careful, and especially dogs, we entertain them so much, they also come and sleep with us. That's what happens. So you should be very careful. And after my surgery, so we're very cautious about it. And this is a live example for you people. And if you have a pet, anybody has a pet in your house? Yes, madam is so very careful. Yes, some students also. So with this session, I thank you for giving me this opportunity to share my thoughts. Thank you.
It was really ice-breaking for all of us, and we wish to take your points into a real practically possible way. So thank you, sir. Thank you once again.
Thank you, sir, for sharing your knowledge on the role of healthcare workers from community level. Thank you, Dikil, sir, for moderating this session. Now we have come to the end of the scientific presentation. Hope all the participants, both online and offline, have gained knowledge from our experts. No program will be ended without showing the gratitude. So now I invite Ms. Alice Joseph to deliver the vote of thanks. So one more request to all the participants, both online and offline, please do the posters. That link will be already sent to your email. Kindly respond it and do as early as possible. Thank you.
Sorry for interrupting. There were some questions, madam. Can we take? Because otherwise they get discouraged.
Definitely, we should take up the questions. I would also ask the kids to, maybe a couple of kids can just sum up, you know, एक point सब लोग बोल दें तो हमें भी पता लगे कि सब जाग रहे थे और कुछ knowledge ग्रहण किया है. तो अगर कुछ लोग can we do that? फटाफट हम 2-3 लोगों से बोले कि वॉलंटियर करके एक पॉइंट जल्दी बता दें कि आज आपको क्या समझ आया. हाँ चलो, थैंक्स दो. गुड जॉब.
On behalf of the Faculty College of Nursing, I would like to thank the Almighty God for helping us to organize this seminar and completing it successfully. I am privileged to thank Professor Gaurav Agarwal, CMS, and Professor B.K. Paliwal, MS, and Dr. R. Harshvardhan. Though they are absent, they were supposed to be here. Due to unavoidable circumstances, they were not able to come. So I thank them for their support and help. Now I would like to thank Dr. Professor Prerna Kapoor, Nodal Officer, TB Control Program, General Hospital, SCPGIMS, for taking the keen interest to initiate us to conduct the seminar, and her eloquent talk on the topic helped us to have undivided attention on the topic. Thank you, ma'am. I'd like to thank Dr. O.P. Sanjeev, Professor, Department of Emergency Medicine, for the topic and enhancing our knowledge with your experience and expertise examples. Thank you, sir. I want to thank Dr. A.K. Baranwal, Animal House, SGPGI, for being the part of this seminar and giving us relevant information on the current scenario. Thank you, sir. Thank you, Dr. Vishwal Gupta, Department of Microbiology, for your valuable time and presence and elucidating your knowledge with us with your example of clinical and also with your research results. Thank you, sir. Now let us take this opportunity to thank the most important persons of this seminar, Mr. Yaditya, Lecturer, College of Nursing, and Mr. Digil, Quality Nurse Coordinator, the organizers for planning, coordinating, organizing, and above all, conducting this seminar in spite of all the problems and difficulties within a short period of time, and taking it and doing it with a lot of courage and with also with the enthusiasm. Thank you for your. I want to thank Mr. Halimani, teaching faculty, for preparing the post-test and pre-test questionnaires for all the faculty and also all the faculties of College of Nursing, coordinating and helping to make this seminar a successful one. I also want to thank the telemedicine department and the technical personnel, Mr. Alok and Mr. Ashok, for providing us with the hall and all the arrangements done to conduct this seminar here, and all the technical help given to us, the net facilities, etc., and with the seating arrangement. Thank you. I also thank the participants of both online and offline in this seminar, giving your valuable time, attentive, and giving a keen interest to show your all the topics discussed here and making this seminar a successful one. Once again, I say a big thank you.
And thank you for the very nice vote of thanks.
Now you can take.
हाँ, I think 3-4 बच्चे जो है अपने हैंड्स रेज करके क्वेश्चन नहीं, पहले ये बताएंगे कि आज के कैरी होम मैसेज क्या था. आई नो कि आप पोस्ट टेस्ट में भी लिख के देंगे, पर वो तो दिखिल और यादिया देखेंगे. हमारे को बता दो कि जो है कि किसको क्या क्या समझ आया. एनीबडी हु कैन वॉलंटियर टू टेल 1 पॉइंट. बोलो. जो हमारे सामने बैठे हैं वो तो अगर हाथ नहीं उठाएंगे तो हम वैसे भी उनसे पूछ लेंगे. तो इसलिए यू आर सपोज टू रेज योर हैंड्स एंड टेल. उससे तुम्हें ज्यादा ब्राउनी पॉइंट्स मिलेंगे. हाँ जी बोलो.
Starting with the introduction, first I would like to tell why we are celebrating the World Zoonoses Day. We are celebrating it as the French biologist Louis Pasteur on 6th July 1885 he administered successfully his first vaccine against the zoonotic diseases. That's why we are celebrating it. And then we learned about how to prevent the zoonotic diseases, especially starting with Sir, like he told us about how to prevent the transmission of zoonotic diseases in animal house and how we are handling the animals there to prevent the bites and scratches and not allowing family members to visit there and handling animals properly, taking proper precautions, PPE kits and all. And then we studied about how to prevent.
Thank you. Another person? Boys? Yes. Very nice.
Good afternoon, Madam. I liked your presentation, ma'am. Very much, very much mesmerizing. The way you told things, it really entered or it gets that is inscripted in our mind. So the management, how we can manage the things.
तुम्हारे किसी दोस्त को या किसी को कुत्ता काटेगा और लाल मिर्ची मलेंगे तुम्हें डांट पड़ेगी.
These are the things that which made us to focus on the points. So like how we have to manage if someone comes with this cases. Then
बता दो what is the tripod of prevention of rabies? 3 point क्या है? 1, 2, 3 जल्दी से बता दो. What is the tripod? 3 points क्या है rabies prevention के? 3 चीजें क्या है?
washing. First of all, we have to wash the wound.
अगला second point.
We have to wash the wound, then we do not have to apply any other things like turmeric salts.
wound हो गया. अगला और क्या करना है?
Then we have to do the vaccination, or
Yes.
we have to go to the doctor.
Yes.
Then as soon as possible, then we should not irritate the wound or apply.
ठीक है.
And
immunoglobulin if required.
That is HRI.
Very nice. Thank you.
And sir, then you told us about the emergency management, how we can do, and that is how it is necessary nowadays. Then Dr. Barnaval sir, he is also our pharmacology teacher.
Okay. Yes. अच्छा.
He explained very well introduced us very well to the zoonotic diseases. Then sir, you also explained very well the clinical your experiences about the stuff typhus disease. That is the name. I like the name of the positive. Sushi. That was very much attractive. And then thank you, sir. Dickens, sir, you very well explained us how we can manage the upcoming disease, that is monkeypox. And then Yagan sir, of course we have to thank you.
नहीं, he means it. It was very good.
Undercurrent है सर ये.
है?
Lectures, so you have
बरनवाल की और यादिंद्र की तो सबको करनी है तारीफ.
नहीं ऐसा नहीं.
Very good. Now we can quickly take questions if time permits.
Yeah. First question, my question was that why should we use bandage in the bite? Why use other types of wounds?
बताओ, तुम बताओ.
Ma'am, I inquired. Should we use the snake bite? That is important there. But they are like a confused why should we use?
इसीलिए कि अगर स्पेशली टाइट और अक्लूसिव बैंडेज से we are pushing the virus more into the wound. ठीक है? So that is why we have to leave it open. उसको साफ करें, उस पर एंटीसेप्टिक लगाएं, उसको खुला छोड़ें.
If we use tight bandage, will that slow the speed of virus to get other?
आप टूर्निके से कंफ्यूज कर रहे हो बच्चे. स्नेक बाइट में जो लगाते हैं वो टूर्निके होता है. ठीक है? ये टूर्निके की तो यहाँ बात ही नहीं होगी. टूर्निके का यहाँ कोई रोल नहीं है. ठीक है? क्योंकि ये नर्व से जाती है. मैंने बताया था ना कि ये नर्व एंडिंग से ट्रैवल करती है. ये तो ब्लड वेसल से ट्रैवल नहीं कर रही है ना. तो टूर्निके का कोई रोल नहीं है और बैंडेज का इसीलिए रोल नहीं है क्योंकि हम जितना टाइट बैंडेज लगाएंगे या उसको कवर करेंगे, वी आर पुशिंग द वायरस मोर इनटू द बॉडी. चलिए, एनीथिंग एल्स?
By this we are closing our seminar. Let us all stand for national anthem.
अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा. विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा. तब शुभ नामे जागे, तब शुभ आशीष मांगे. गाहे तब जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
Thank you.
Thank you.
Thank you for very much.